here Dr. Laura Jacks. Dr. Jacks is a board-certified orthopedic surgeon specializing in pediatric orthopedics. And her specialty really interests include cerebral palsy and all neuromuscular diseases. She's the medical director of the Kids Center for Pediatric Therapies in Louisville. She earned her medical degree from Hahnemann University in Philadelphia, Pennsylvania, and completed her residency at South Carolina's Richland Memorial Hospital. She did her fellowship in pediatric orthopedic surgery at Shriners Hospital for Children in Greenville, South Carolina. This morning, she is going to talk about child limp.
Hi there, I am Laura Jacks. I'm going to try to share my screen here. And, oops, get back to the beginning. Sorry, helps to have it on the first slide. Okay, so we're here to discuss various different topics. The overall theme of the symposium this year is spine and sports, and those are two things that I don't really specialize in. As you heard Dr. Meyer say, I'm primarily into neuromuscular syndromes and such. And while all neuromuscular kids have spines, and some of them have spine problems, and many of them play sports, it's still not really a specific area of my focus. So they gave me the fluff talk. So this is the talk about children limping and whether or not perhaps that limp could be due to a sports injury. I do also have a 15-year-old son who plays sports, and I'm here to tell you that 99% of his injuries are overuse related. So I'm going to say yes, your child's limp may be due to a sports injury. I am a stock owner and surgeon advisor for the company Orthopediatrics, but that's really nothing to do with the talk that we're going to discuss today. So there are various reasons to limp for kids and adults, I suppose. In many cases, there's at least some trauma, whether you just stubbed your toe or broke your ankle. So trauma probably, especially in an orthopedic office, is one of the number one things that we're looking for. In most kids, the highest likelihood of fracture is from the knee down, so tibia, foot, ankle, anywhere in there. Overuse is very common. If it's an overuse syndrome, it can have to do with a muscle or the bone. You can have a sprain of a joint. It doesn't always have to be broken, although once you come to the bone doctor, diagnosis of break is pretty high. I think when you go to your pediatrician, the diagnosis of sprain has to be higher in the whole scheme of things. Septic joints are something that we always have to keep in mind. It's not always easy to tell the difference. We have been fooled ourselves between a septic joint and a possible occult fracture. So I think that's something to always keep in the back of your mind. And then also, oddly enough, congenital issues, even though the child has potentially had this all their life, sometimes it really doesn't become noticeable or noticed until the child plays a sport and it draws the attention to the difference. So one thing to always keep in mind is that not all fractures are visible on x-ray. I think this is by far more common the younger you are, but even adults have fractures that are not visible on x-ray. I hear this all the time from my coworkers who say, I hurt my blankety blank and then I went to get an x-ray, but the x-ray is negative. The radiologist said nothing's broken. Well, you know, the radiologist isn't touching your bone, and somebody actually needs to touch your bone to see if it's broken or not. And so sometimes even if the x-rays are negative, if the pain is enough to warrant it, you should still splint it or brace it until it feels better. This is just an example of a toddler fracture. So this was a little kid who came in and x-rays. The first two films, yes, on the left are negative. There's no callus there at all. And then the second two on the right show callus. So sometimes people will say, well, go get another x-ray in 2 weeks and see if there's callus forming there, or 3 weeks or whatever. And then if it shows that, then we know it's broken and we'll send you to the bone doctor. But the films on the right were done at 3 weeks after the injury. And at that point, we took the cast off and it's healed and finished. So at that point, if they come to us, we're not going to put a cast on. So sometimes it's not obvious on those previous films, and sometimes it's obvious. You can see on the film on your far left that the tibial tubercle is completely popped off the front of the knee there. This happens when the patella tendon pulls so hard on that it just rips the whole thing up off of there. This is most common, I suppose, in basketball. And it's actually not when they jump, it's when they land that it most often happens. So you can also see these two films were done on the same day. This film was done with the knee in maximum extension. So it will reduce closed without having to have, screws or whatever put in it. But anytime the knee is bent at all, it immediately displaces again and looks again like that first film. So a couple of screws later, and she's back on the court doing great. Sometimes it's really obvious like this, which was a helmet to the head or helmet to the leg. The initial injury was in October, and then the following end of July are the films on the right after some remodeling. And he went back to football. I thought he was a few months early, but his parents were willing to take the shot and go back. There is reformation of the intermediary canal, which means this lighter gray, or I guess darker gray area here that kind of goes through the middle is reformed, which means the bone is pretty strong. And you can take a bone that was really this crooked and have the body make it that straight all by itself, which is fabulous. Sometimes it is not obvious, but still needs surgery. So this film on the left, you can barely see the crack going through the joint there. It's not bad. This is what I call one that's really riding the fence, whether it needs surgery or not. But when we looked at these two cuts on the CT scan, this one at the bottom really shows that this lateral piece, which is actually on the coronal cut or on the axial cut here, is near the fibula, is this piece, which isn't really even the free piece. Looks like it's the one that's displaced. So that means all the big joint surface is displaced against the medial malleolus. So we went in and put that screw in. It's a single screw. It's a relatively simple, small procedure, and it went very well and helped the child heal and didn't even get a growth arrest, which was just a bonus. Sometimes when kids come in and there's over and over again another fracture, you do have to keep in mind child abuse or the possibility that the kid has an underlying OI, which is even less likely. But always keep in mind the possibility of child abuse, even in an elementary age child that may be facing something that you can't even imagine at home. I think it's a good idea that if it crosses your mind, you should always report it. Stress fractures are also fairly common in childhood. They may not always be called stress fractures. Overuse injury, it's all typically at the waxing and waning pain. And in pediatrics that I've seen, I most often see metatarsal stress fractures and tibia stress fractures. I've seen a few femoral necks, haven't seen very many in other bones, but they do happen just about anywhere you can have any increased pain. Typically, it's with a change in activity level, whether it's because they went from one sport to another or doubled, had a couple of weeks of doing two sports at the same time, which was an overdoing it, or just maybe never had a break, maybe a nutritional change or reaching puberty suddenly or something like that. So when you're this active all the time, every day, some sort of practice, every day contact, every day twisting, then you are going to have injuries. Some of them are going to present as muscle strains. Typically, when I tell my son he has a muscle strain, he's very disappointed that it's something so stupid sounding can be so painful and so limiting, but it really can be a big problem. In a soccer player, the biggest one that I've seen that takes the longest to heal is a Rectus femoris strain, which if you've ever had it, I've had it once, but when you're kicking the ball, anytime you try to extend your hip or extend your knee while your hip is a little bit flexed, which happens when you kick the ball, you get horrible searing pain down the front of your thigh. And it's quite something, and is very much going to be a problem that's going to limit your ability to run, to walk, to climb steps, to descend steps, to do anything. And the treatment is you've got to just not do anything for weeks until it heals. And then you have to slowly work your way back into the game. And when the diagnosis is muscle strain, that's very disappointing. The one that is the worst that I really just dread hearing is the sports hernia, which is sports not a hernia. It is not a hernia. It is not a hernia. It is a muscle strain. The real name of the injury is called athletic pubalgia. Really, that's the name of it, but you can see why nobody calls it that. So because it's right there in the inguinal area, people call it athletic pubalgia. And I tell the kids that come in that have had this, that my nephew had this problem, and I told him that's what it was. And I told him you need to sit out for 3 months, just sit out. The AAOS website says to sit out for 2 weeks. Let me tell you, that's not going to get it. Sit out for 3 months. You got to really sit out. I mean, sit out. Don't go to PT. Don't strengthen. Don't stretch. Sit out. And it took him 8 or 9 months. He lives in Virginia, and he kept trying to go back early. And they were so frustrated with this, and they of course didn't believe me any more than my own patients do. And he wound up with 2 MRIs and a general surgery evaluation to see if he could get that hernia fixed, et cetera, et cetera. It's not a hernia, so it's not going to get fixed. So it's time that it takes to get it better. But it is actually, you can see on his MRI a little bit of irritation even in the bone because he got so bad before he stopped. Other causes of hip pain can be all the things that worry us, and other things that are minimal. We already talked about muscle strain, but there's also toxic synovitis, hip infection, Perthes disease, slip epiphysis, and all these things should kind of at least enter your mind a little bit. They enter our mind a lot. We're going to talk about more of these. I think the 2 of the hard ones to differentiate are septic hip and toxic synovitis. Toxic synovitis is not as common in the athletic age kid, like your higher elementary to middle school kid. That's not as common in that age. It can happen, but the symptoms are so similar to septic hip that it becomes very difficult to work out. One of the things that's very different in an older kid, they can tell you that a septic hip gets worse. Toxic synovitis just kind of stays the same. It's bad, but at least it doesn't get steadily worse, even with Motrin on board. So you've got the comparison there to look at. For Perthes disease is avascular necrosis of the femoral head. It happens just out of the blue in some kids without any risk factors. Some of the kids do have a vasculitis tendency or a clotting issue. They find out about this way, but by and large, most of them, the great majority of them, have no risk factor for having clotting or any kind of vascular issue. It typically does not happen before age 3. I've seen it before age 3, but not very often. The prognosis is markedly better if they get it before age 8, and after age 8, it's really markedly worse. There's a real cutoff there. Really, before age 6 is the best. The disease process lasts about 3 years before it completely resolves. Sometimes we brace, sometimes we do surgery to try to put the ball deeper in the socket and help things form better. But once puberty has started, if they haven't had Perthes disease onset by then, once puberty has started, we don't call it Perthes anymore. We just call it AVN. So let me show you a case here. So this is a kid who comes in with just hip pain and no specific other complaints. The right hip, though, is extremely stiff, and you can even see the hip in the view on your left in the AP view. They're tilting a little bit to that side, and it's extremely touchy. This was a year later or so, and that right hip has gone on to pretty stark collapse there, and it's starting to be a little bit funny shaped in the film on the far left. In this case, no surgery was done. You could have argued, by the way, that a surgery needed to be done there, and I wouldn't have disagreed at that time. This is not my patient. This is one that was a colleague of mine back in the day when I was in training and early job. But this is a much later film. Let's see, So yeah, this is before she got discharged, or he got discharged from the office. And you can see the shape of the femoral head on the right, on his right, your left, is not very well shaped, but fits in the acetabulum well, and he's completely asymptomatic. And given enough time, lo and behold, it actually looks pretty good, and it rounded itself up, and he's doing very well with that funny shaped hip in that funny shaped socket, and still to this day has not had a hip replacement 20 years later. So onto slipped capital femoral epiphysis, or we call it SCFE, not peanut butter. The SCFE is most common in obese Black males, but I've seen it in skinny white girls. I've seen it in every size, age, whatever. And to me, honestly, I've seen it the least in obese Black males, but that's what the books all say. So I would say that if you have somebody who comes into the office and is walking with one foot turned out, and they're having a little bit of difficulty walking very well, you have to consider a SCFE as a cause, even if they come in and they really point at their knee. They almost all point at their knee as the source of pain. So rarely, by the way, it can be on both sides, but always make sure you look at the hips if they present with some knee pain, at least by exam. Check and make sure that when you rotate the hips, you're not exacerbating the pain. This is an example of one that is pretty subtle on the AP pelvis view. That's the upper left view. I like on this AP view, it's very hard to see, I will say. I put these lines on here. Those are called Klein's lines. And I don't expect you guys to remember that, but understand that there's a difference. If you just look a little bit, it's subtle on that first view. Oops. But if you look a little bit at the ice cream on the cone there, you can see the ice cream is sticking out past the line on the patient's left hip, but is not sticking out past the line on the patient's left hip. And that's what tells you that it is a slip. There's asymmetry there. And I think if you look at the line of the epiphysis, or the line of the physis, it's more of a frowny face on the affected side. So the side that's affected is sad or awe. And then if you look at the frog lateral view, it becomes more obvious that the ice cream is falling off the cone on the patient's right side and not on the left. For those of you in radiology, and some pediatricians are going to look at these little clippies in his gut and think that he swallowed something, but nope, those are the little grommets on his sweatpants. Don't worry. So on this is the view of the same kid after surgery. We just put one screw in there, and the idea is to stick a screw in there and let the body do its thing and heal that. So it allows the growth plate to heal across there. Yes, it closes the growth plate. We put threads across the growth plate so it closes that growth plate, but that growth plate is only responsible for probably at most 2 millimeters a year of growth. And so closing that down is not a big difference for the height of the child. And seriously, if the head kept falling off, that would be responsible for a loss of more than 2 millimeters a year. So it's all good. It's a good trade-off. Also, just again, another reminder, check the hips. So this is an x-ray that was done in June of this particular year after the child had been complaining of knee pain for 3 months. And this was done not at our facility, but it's documented. It's there. It's in the computer. And then 4 months later, he came back and had knee films again. And then somebody said, you know what, we should check the hip. And this dismal, horrible looking thing is his hip. And aren't you glad I didn't show you this one first? Because it's hard to even tell there's a hip there. So this is a terrible slip. It's so far off that it no longer even really looks like a hip. You can't tell there was ice cream on there. It's all misshapen and smushed off in the back. On the frog lateral, you can barely see the outline of the shape of of the femoral head here. It's going all the way back, just touching the neck here. It has slipped way off and it's chronic. So he says he's only had pain for about 7 months, and I would argue that it's been longer than that. We can't fix that, by the way, with a single screw. So that kid needed the single screw to get it to calm down, and then later had a big osteotomy to change the shape of his hip. And he's doing okay. I have access to his film still, and there's still no total hip film in there. So that's a good sign. And that was 11 years ago now. Next we'll move on to apophyseal avulsions. Apophyseal avulsions, that's just an apophysis is a small area of bone where a muscle attaches, and there's a small growth plate in there. So apophyses are common around joints. So there's a ton of them around the ankle and on the pelvis. That's the most common location for these. But any apophysis, anyone can avulse off the bone because the muscle pulls so hard, it just pulls that piece of bone off the main bone. In the pelvis, those are the most common. Oops, I forgot to put the iliac crest down at the bottom there. The iliac crest, the muscle that avulses off the iliac crest, is the abdominals. In the foot, the most common avulsed muscle is the fifth metatarsal base, I suppose. We're going to talk about pelvis ones because they're kind of fun to talk about. They hurt a lot. They are in your axial skeleton. And so once you have an avulsion of a muscle in this area, it hurts so bad because everything else is centered off of your pelvis. And so you have a little tiny injury to this bone in your pelvis, and all of a sudden it's like your leg is dead. You can't lift up the leg. So here's a boy who comes in at his initial presentation. His x-ray is negative, but he can't walk. He can't lift up his left leg. He literally cannot advance it in front of his body. He can kind of pull it along the ground with his other leg, but he really looks like somebody faking a limp. That's how these kids basically walk. 6 months later, he came back. There was, for some, I can't remember the reason. There was a big reason why he had a big delay in his return for follow-up. But when he comes back, you can see this healing giant mass over here. So it's not a tumor. That's the healing injury that he had at first. That's his AIIS, anterior inferior iliac spine, which is the origin of his rectus femoris, and pulls it off, and then it heals with all that robust bone around there. And it's fine. He's a soccer player. He'll get back into the game and do fine. But he probably, during that 6 months, wasn't feeling a whole lot better for quite a while because that was pretty significant. The iliac apophysis, which is the Risser sign. If you look at an x-ray, this girl is Risser 4. But if you look at the frosting on top of the iliac crest here, you want that frosting to look symmetric. And if you look at the frosting on her left hip, on your right, on her left, there's a very narrow black line between the gray frosting and the gray iliac crest. And on the right side, it's elevated up off of there. And that is, in fact, exactly where she's hurting. It was a field hockey injury where she did get sticked, I guess that's the proper terminology, in the hip, and had an acute onset of pain. But I think it was her abs as well as the stick that caused that. Just for fun, I'll point out to you down here, this is the ischial tuberosity, where it looks like there's a little bit of frosting on the bottom of that bone. That's where the hamstring originates, and occasionally that's a source of an avulsion as well. Sometimes you just have a kid who comes in and the mom says, my kid just doesn't run as well as other people. And I noticed it when they played sports. And sometimes that is the time when I diagnosed for the first time a muscular dystrophy or a hereditary sensory motor neuropathy or something like that, which maybe is a progressive thing and so wasn't as obvious earlier on. Or sometimes you diagnose things that were really there all their lives, and we'll go over a couple of those as well. One of those that can be there that was there perhaps all their life is a leg length discrepancy. So sure, sometimes a leg length discrepancy happens because of a prior trauma or whatever, but I've had kids come in and had a leg length discrepancy because the hip was dislocated or there was some other major prior abnormality that just hadn't been seen. So sometimes we'll order fancy studies to look at this, but by far the most important thing to do is just look at the patient, see what else you see. So here's a kid who comes in and you can see something's not right. His pelvis is a little bit unlevel. He was actually sent to us for evaluation of scoliosis because he stands and looks so crooked. But really what his problem was a leg length discrepancy. And when we put him on a block, a pretty big block, mind you, so his leg length discrepancy was not subtle. He's 7 years old. He's an athletic, active kid, and nobody noticed anything until somebody looked at his spine and said it was crooked. Oh, by the way, he only has 4 toes on that side. Hint, hint, clue, look at the kid and see what else is going on. So 4 toes on the left side, big leg length discrepancy. He has fibular hemimelia or fibular deficiency, and it's a pretty easy fix for him, really. This is one of the things that can be done. This is the same type of thing. This is if you had a deficiency of the femur on that side. This is femoral deficiency, proximal proximal focal femoral deficiency is what all those letters stand for. And we can put in a rod that slowly lengthens the femur over time and winds up with a pretty good outcome. So you start out with this picture on the left with a 7 centimeter leg length discrepancy. The rod lengthens 1 millimeter a day with some effort from the patient. And then slowly the bone fills in and you have the leg normal length. Occasionally we'll have somebody present with an arthritis that starts out when sports ramp up and becomes more obvious. And that's most commonly in the elementary to teen years. But that comes with your rash and your typical appearance. And then occasionally we'll have some developmental issues that were just, that become exacerbated at that age and with activities. So this is an example of a boy who has his foot his feet are asymmetrical. The right foot is a little bit turned out. The left foot is drooping down normally when he sits on the table, and that's perineal spastic flat foot. His perineals are in spasms simply because his foot hurts. And he can't stand on the toes on the right, but he can stand on the toes on the left. Lo and behold, he has a tarsal coalition, which the two bones, the navicular and the calcaneus, are not supposed to touch there, and they're touching. So after surgery, it looks like this. He has all kinds of room. He kept, getting injured in sports. He kept hurting that foot coming in, for multiple sprains and whatnot. Turned out he really did have a problem where his foot wasn't moving normally, and that's why it kept getting sprained. Here is, actually, this is my niece who has had Osgood Schlatter's disease that was horrible. Look, her knees are so ugly, but very sticky outy in the front from her Osgood Schlatter's disease. There's nothing to do for that but wear braces and do everything preventative and stop kicking balls and stop running, but that's not going to happen. So the Chopat strap is the #1 thing, and the knee immobilizer is another thing. I had her alternate sides with a knee immobilizer at night just to give it some rest sometimes, so she wasn't sleeping all curled up. This is a friend of my son who had Seaver's disease so bad, and it lasted years, and it lasts years. So the first film is when he was 12, and the second film was when he was age 14, because they just couldn't believe that it could still be lasting that long. But it was, and there it is. He had nothing wrong, just Seaver's disease. And really, it's gone now. It still is a friend. And by the way, he did go get another second opinion at a different office just to make sure we weren't missing anything. And I don't blame him. It was really painful. For Seaver's disease, we recommend a soft heel support, or if you want to sleep in something, you can order this nice brace off Amazon, but please don't pull it up past 90 degrees. You're just causing more pain. And that's it. Sorry if I ran over. If you have any questions, I'll stay live here for a little bit to answer some questions.